Good afternoon, and thank you so much for joining us today for the COVID-19 Town Hall for CHWs. Where are we with variants and where are we headed? My name is Dina Pimenova. I am the Senior Project Coordinator for the NYU Langone Community Health Worker Research and Resource Center, housed in the Department of Population Health at the NYU School of Medicine and supported by the NYU Langone Community Service Plan. Today's event is hosted in partnership with the NYU Community Engagement Alliance Initiative, NYU-CUNY Prevention Research Center, and the NYU-H&H Clinical and Translational Science Institute. Next slide, please. Before I introduce our speaker, I would like to go over some housekeeping briefly. Everyone is on mute. You can enable or disable closed captioning by selecting live transcript at the bottom of the screen. The chat box is open for comments and sharing of resources. If you are trying to reach all attendees, please select everyone, not just host and panelists. We ask that you please use the Q&A box to submit questions to the speaker. We will have time to answer as many questions as possible during the Q&A portion. The slides and the recording will be made available. I will email those out as soon as possible. And please be sure to fill out the poll at the end. Next slide. This webinar is geared primarily towards community health workers and frontline staff working directly with community members. We will first have a presentation on COVID-19 variants and how to make sense of the current recommendations for self-tests, quarantine, and isolation. This will be followed by a Q&A. And our speaker today is Dr. Anna Bershteyn, who is an assistant professor of population health at NYU Grossman School of Medicine. She advises the New York City Department of Health and Mental Hygiene on COVID-19 forecasting. She was previously a senior research manager at the Institute for Disease Modeling, where she developed mathematical models for global disease control and eradication. Our Q&A moderator today is Ms. Sheila Willis. She is a community health representative and patient navigator with the Beatrice W. Welch's Breast Health Outreach and Navigation Program at NYU's Perlmutter Cancer Center. Her role consists of helping medically underserved women in New York City access mammogram screening, diagnosis, treatment, and post-treatment services and support. Her mission is to bring awareness around any resources that can help a person lead a healthy and fulfilling life without illness. Ms. Willis is also a certified fitness trainer. And with that, Dr. Bershteyn, the floor is yours.
Thanks so much, Dina, and welcome everyone. It's really a pleasure to be here with all of you. And I'll just start us off by talking a little bit about where we are, situational awareness. I know many are zoomed in today from New York City, so we'll talk about the national picture for those of you coming in from around the country, and then talk a little bit about what's happening here in New York. And then we'll just talk about where we are in terms of testing and quarantine guidelines, vaccination guidelines, and then prevention measures, which are a little more loose, more about individual decisions. And then we'll move over to Q&A. So I'm really looking forward to your comments and questions for this hour. So first slide, please. So this is just a picture of where we are with COVID cases right now nationally. This is total for the United States, and in purple, a forecast from many different mathematical models. You can see the link there. They frequently update their forecasts. And so you can see where we are is we have shattered records, but thankfully the United States as a country is in rapid decline with COVID cases. And you can see that continued decline is being forecast by many of the mathematical models here. Next slide. If we take a look now at hospitalizations, you can see hospitalizations unfortunately also did shatter records on a day-by-day, week-by-week basis. So we've had this increase that was not as prolonged as some of the prior waves, but really was quite sharp. So a brief but really intense period for the health system. And just like cases, the forecasts are showing nice declines in hospitalizations, although we're still at quite high levels at this moment. Next. And then as a nation, where we are with COVID deaths. So unfortunately, we have gotten to the highest levels since what was seen in January of 2021, when vaccines were just starting to become available. But the forecasts on the whole do show that deaths also will decline as cases and hospitalizations decline. But we are looking at a period of time where we will have relatively high daily rates of COVID-19 deaths across the country. And that's just a consequence of having been through this surge of cases. And now people who've had COVID are now in hospital, and most will make it, but some will have some severe outcomes. Next, please. So just zooming in for a moment in terms of where we are in New York City. Are you seeing the next slide? Here we go. So, actually, before we zoom in New York City, just to point out, that even when we average across the country, a big country where COVID ping-pongs around from region to region, we can see that each of these waves has been driven by a different variant of SARS-CoV-2. So we had our original or ancestral, some people call it the wild type variant, that originally hit New York City very hard in the spring in the Northeast and then moved around the country. Then we had the Alpha wave and then the Delta wave and now the Omicron wave. And if we actually go one more slide to look at the New York City picture, when you look at just one area, you can see this much more clearly. So in terms of New York City cases, we had the original wave really confined in this area to the spring, and then it hit other parts of the country more in the winter time. The Alpha wave, the Delta wave, and then this really incredibly large Omicron wave, again, really shattering records with quite a substantial proportion of New Yorkers becoming infected and diagnosed with COVID-19 in this time. Next slide, and we can just take a look at hospitalizations and deaths by wave. A similar story in New York. The Omicron wave was really condensed into a very short period of time in New York. So the curve was not very flat, and hospitalizations did reach a high level on their highest days. And then next slide. And then deaths again, reaching some of the highest, not the highest levels that have been seen in the worst wave, but getting to significant levels along the lines of what was seen last winter. And thankfully, deaths in New York City are now on the decline. So we can see in general in the Northeast and in New York City in particular, things started a bit earlier, very intensely, and now things are falling a little bit earlier. And that hopefully should foreshadow what will happen in the rest of the country with declines coming down from this wave. So we've seen these cases, next slide, hospitalizations and deaths by wave. And one thing that's really clear is each successive wave of this pandemic seems to be caused by a distinct variant. And variants are different from one another because they have genetic mutations. So this graph here shows how far different viruses are from one another based on what we call the genetic distance, how many mutations they have. So being farther apart with longer lines means longer genetic distance. And you can see from sort of where things started at the beginning, there have been a number of lineages of Delta, which are quite different. You can see some of the earlier variants, Alpha, Beta, and Gamma, which are also different, though by not as much. And then you see Omicron, which is really a whole new branch on the family tree of SARS coronavirus 2, with a very large genetic distance from the original strains, and clearly not having evolved from one of these other major variants. And you can also see that Omicron groups into two different lineages that we've detected so far. BA1, which is the one that really drove this last wave that we've seen in the United States, and BA2, which is kind of a question mark. We're not yet sure whether BA2 will drive a new wave or whether it will just maybe prolong the shoulder of this wave, or whether it won't really take off at all. But it has been detected in some countries, particularly in Northern Europe. It sort of took over as Omicron was rising and seemed to make the wave peak even higher. And in other countries, it seemed to kind of create another hump. So it just depends on the timing and how distinct this variant will be. So next slide. This is just something for all of us to flag, that we don't really understand this thing yet. It could prolong the current wave. Or maybe this thing will keep evolving and a different variant will cause the next wave. Next slide, please. So variants are a big problem. They cause these pandemic waves. What can be done about them? So I think the first thing that we need to prioritize with variants is trying to reduce transmission globally. The more transmission there is, the more chances the virus has to mutate. Every time it replicates, it can mutate a little bit more, and that gives opportunities for variants. So really focusing on providing access to vaccines, tests, and PPE to populations that don't have access to them. We know in particular people with immune suppression can contribute to variants because they tend to be infected for a very long time and have trouble really shaking off the infection. So treating immunosuppression, right? For example, making sure that people living with HIV are able to access and adhere to treatment. That can help us in general. And then the other possible source of variants is, in particular, these viruses seem to spill into animal populations rather readily. And we know they can spill from animals into people because that's how this pandemic started. So potentially reducing contact or practicing precautions when interacting with animal populations that are infected is another way to help reduce the risk of another variant. But variants could come. They've come several times already, and we have every reason to think that there could be another wave from a new variant. And so when they come, the solution is to sequence cases as broadly and as equitably as possible. There are parts of the world, especially sub-Saharan Africa, where there are areas with very little capacity to do sequencing. So we want to make sure that we're helping everywhere we can for countries to have access to sequencing, to be able to share their sequencing data. So that includes incentivizing instead of punishing countries. With Omicron, South Africa was the first country to report the variant, and travel bans were imposed, which is quite economically damaging. So for some of these countries that have not as strong of an economy, that can be extremely damaging. And so we need to think of policies that actually encourage rather than punish reporting of variants. And then we also need to monitor case severity through our health system so we can spot it really quickly if there's a variant that is very severe. We also need to prepare technologies for the new variant. So that means accelerating vaccine and treatment updates. It's really amazing that we are living in the era of mRNA vaccine technology, because that's a technology where the vaccines can be updated very quickly. The sequence is changed, but the same basic technology is still used to deliver the vaccine. However, we know from Omicron that it's about a 3-month process right now, and that's a very long time to wait when you have a new variant. So thinking about how to speed up that process. Also, spotting variants early across borders by testing travelers and sequencing travel-related cases can help. And so having the infrastructure to do that at our ports of entry, I think would be really helpful. We already do travel testing and then layering sequencing on that, and then having PPE ready, knowing that another variant could come. And then, those are all things that many of us don't have a lot of control over, other than advocating to our leaders that we want our governments to invest in these things. But there are also things that we can do in our own communities. So one of them is, we know that with things like testing, there might be very little demand when transmission is low, and then a huge surge of demand. So thinking ahead and planning for surge capacity, right? What are things that staff can do that's wonderful and useful between waves, and how can we pull those staff in to meet demand for COVID services when we have a surge, when we're in the middle of a wave, sort of planning that ahead so it's not a scramble in the moment. Creating, I think, a lockdown blueprint in a way, so that if we do have to have a shutdown again, if we do need to have some restrictions on businesses or schools or movement or anything like that, if we get a severe variant, that we have a plan, and a plan that really prioritizes and protects vulnerable populations. Because again, when we're making it up as we go along, we don't make optimal decisions, in particular in terms of equity. And then finally, just being ready with practiced and refined social distancing protocols. So many of us now have experience with this, all these different things. We all know how to wear masks, buildings with stairways that you only take up or only take down, all of these details of how to actually implement COVID safety measures in the community. They need to become sort of like fire drills, some things that you practice in case you need them, so that you're not caught unpracticed and unable to put them in place when you do need them. Next slide, please. So with that in mind, in terms of where we are and where we're going, we can review what the current guidelines are and how we should all be behaving in the meantime. And these are guidelines that change quite regularly. So we'll just quickly review here guidelines for testing, isolation, and quarantine at this moment. And do check the CDC webpage often because these guidelines are frequently updated. So at the moment, we're fortunate that we have access to at-home antigen testing, and coming out of this Omicron wave, there's not this great shortage and surge of demand. So it's relatively straightforward to gain access to these tests. And there's a government program to gain access to no-cost tests as well. So if you have COVID-19 symptoms, it's recommended to test immediately. For a person who was exposed to somebody with COVID-19, it's recommended to test at least 5 days after exposure. And if that's negative, to retest 1 or 2 days later to see whether there was a transmission. And then if there is a gathering, in particular, a higher risk indoor large gathering, maybe any gathering where there's not great air, fresh air exchanges, masking, anything risky like that, it's a great time to test, and you really want to test as soon as possible before the gathering, because somebody could be negative and then a few hours later turn positive. And if a test is positive, that means that the test did detect the virus. There is an infection, that person is contagious. So it's important to stay home for at least 5 days and to isolate from others in the home. It's important to inform close contacts. Locally, if you have a tracing program like we do in New York City, that can be a great way to get yourself and your close contacts resources to be able to isolate effectively and safely. After those 5 days, you will want to continue to practice precautions by wearing a well-fitting mask around others, or even during that isolation in your house, if you're having to be near family members, wearing a high-quality mask, preferably an N95 or a KN95. And then, monitor yourself for symptoms and get care if you feel like you need it. For example, if the oxygen saturation is low, if your test is negative, that doesn't mean that you're necessarily not infected, because these viral loads go up and they go down. So you do want to test repeatedly, and you do want to practice precautions even if that initial test was negative, just in case, because you could become positive at any moment. Next. For someone who is positive, just to reiterate here, the current CDC guidelines are that regardless of vaccination status, people must stay home for at least 5 days and isolate as well as possible as well from people inside the home. This is a shortening from previously a longer self-isolation time, but this is also a minimum. So if you are, there are people in your community who are higher risk. If you're in a situation where you can self-isolate for longer, maybe you're able to work from home productively, you can go ahead and do it for longer, and so much the better. You might prevent more transmission, but it's a minimum of 5 full days. After those 5 full days are over, you need to continue to wear a well-fitting mask for an additional 5 days, for a full 10 days, where you're being as cautious as possible around transmission. And you also need to not travel for those full 10 days. For people who are immunocompromised, that full home self-isolation should last at least 10 days. And we'll talk about what immunocompromised means. So a bit longer for immunocompromised people. Next. And then the guidelines for quarantine. So this is someone who has had exposure to a COVID-19 case. So maybe you were notified by a contact tracer, or by your organization, or by that person. But if you're aware that you've had close contact with somebody with COVID-19, then what you need to do does depend on your vaccination status. So if you are up to date on your vaccinations, and that does include your booster if you were eligible for one, or if you have had COVID-19 within the past 90 days, and that means a positive viral test, either an antigen or PCR, and you're now out of self-isolation, presumably, you do not need to quarantine. If you are up to date on vaccinations, you need to get tested at least 5 days later. If you've had COVID in the past 90 days, you don't need to get tested. Your PCR test actually could be a false positive at that point, so you just don't need to quarantine. You should watch for symptoms, and you should take precautions for 10 days. So that means primarily wearing a well-fitting mask, staying away from crowds, do stay away from vulnerable high-risk populations. So don't go into a nursing home at this point if you've had exposure, even if you're vaccinated. Next slide. And then we have different guidelines right now for people who are not up to date on vaccination. So for people who are not up to date on vaccination, it's sort of similar to someone who's tested positive, where they need to stay home for a full 5 days, wear that well-fitting mask around people in the home. And then after those 5 days, an additional 5 days of avoiding travel and wearing the well-fitting mask and taking general precautions. So that's a little bit like the protocol for someone who's tested positive, but now for people who are exposed, who are not up to date on vaccinations or recently diagnosed with COVID. So, start thinking about your questions. These guidelines change often. Let's quickly go through the guidelines for vaccination next. Here are vaccination guidelines. So guidelines on the initial vaccine series. So I know many have already had their initial vaccine series, which would have been 2 doses of either the Pfizer or Moderna vaccine, or 1 dose of the J&J vaccine, or if you were vaccinated internationally, whatever was the recommended primary series where you were vaccinated. So the current guidelines are the Pfizer 2-dose series, which is 2 doses given 3 weeks apart, is recommended now for anyone ages 5 and up. Unfortunately, still no approved vaccines for under 5. The Moderna vaccine still for ages 18 plus, and that's 2 doses given 28 days or 4 weeks apart. And then the Johnson & Johnson vaccine, we'll see their updated guidelines here. What's called the primary series is still considered just 1 dose, but they are recommending an additional dose for people who have received the J&J vaccine. So for all of these vaccines, you're considered fully vaccinated 2 weeks after you complete that initial series. And as of now, the guidelines are it's okay to get other vaccines in the same visit as the vaccine. It's okay to vaccinate after a COVID-19 infection, with just a couple of exceptions if someone has had monoclonal antibodies or convalescent plasma in the last 90 days, or if they have had MIS-A or MIS-C, these inflammatory responses in the past 90 days, then they need to wait. And the other great thing is most medical procedures are fine after the vaccine, just with some exceptions. For example, a lot of providers will ask that you postpone a mammogram for about a month to a month and a half to let the swelling go down in case there's some swelling after the vaccine. So these are really intended to make it easy. You can get your flu shot in the same visit if you're due to get that primary series. Next slide, please. And then these are exciting new guidelines as of January on additional doses and boosters. So there are really 2 things that are recommended. One is an additional shot for the primary series. So this is what it would take to be considered fully vaccinated or having completed the primary series. And that is for people who are immune compromised. And there's a list here in tiny font because there are a lot of different things that could mean immunocompromised, but basically cancer treatment or organ transplant patients who are taking immune suppressive treatments, people with, again, stem cell transplant, immune deficiency due to DiGeorge syndrome or similar, untreated or advanced HIV infection, and then taking high-dose corticosteroids are some common reasons for being immune compromised. So for people in that category, they should get an additional dose 28 days after the second shot of an mRNA vaccine. And there are now recent guidelines for getting an additional dose of the J&J vaccine as well, from just recently from February 11th. So if you look up this table, it'll look a little different from here because there's the updated guidance for J&J. In general, for people beginning their primary series, the CDC has recently said it is preferred to take the mRNA over the J&J, except for people with particular reasons like an allergy to the mRNA vaccine. So that's preferred, and certainly for people who are immune compromised. And then there is the booster shot. So the booster shot, again, for Pfizer, the Pfizer vaccine, it's for ages 12 and up. For Moderna, it's ages 18 and up. Both of these are taken 5 months after the primary series. And just on February 11th, there was an update that people who are immune compromised, so again, part of these categories, can take this 3 months after the primary series. And then just one final note here. This is a lot of confusing information, but it's okay to mix and match booster doses. It is not recommended to mix and match the primary series or the additional shot right now, just because there isn't the safety and efficacy data. In general, studies show that the immune response is really good to get either mRNA vaccine on top of an mRNA primary series, or to get an mRNA vaccine on top of a Johnson & Johnson vaccine. So both of those are great options for the booster. Next slide, please. So where are we actually right now with vaccination? So let's take a look first locally here in New York City. You can see that coverage overall in adults is at around 85% right now, which is great to see for 18 plus. A little bit less for younger folks. So 5 to 12, we're still at just 40% coverage with completing that initial series, which for most will be the 2-dose mRNA series. For 13 to 17, 77%, so getting there. And then what's really great to see is in these older age groups, we're getting to nice high coverage in New York City. We do see a fall off in the 85 and older, so we need to make sure we're getting coverage in our oldest, most vulnerable populations. In less good news, we are not doing so well with equitable coverage. You can see in particular in our Black New York City populations, we're not doing as well with coverage. And no real difference in coverage by sex here among adults. And then the heartening thing to see, if you look at the graphs on the right, is even though our slope is not as high as it has been, we are continuing to make progress in total doses. So we saw some nice progress in the booster dose ahead of the Omicron wave, but we're still making progress on our doses 1 of 2 and doses 2 of 2. And every time it gets harder to continue to make progress because those who are still unvaccinated likely have some barriers, some hesitancy around vaccination. And it's really thanks to our community workers and our outreach, our community-based organizations, neighbors and providers and people who are having these conversations with people and helping them overcome their barriers, that we do continue to make this progress. So really shout out to everyone who's had those long, time-consuming and tough conversations to help someone overcome vaccine hesitancy. We still make progress every day. In the US, 500 or 500,000 doses ticking along every day, thanks to all that hard work. So next slide, where are we in the US right now? You can see overall in the United States, we're at 24%, 5 to 11, 57%, 12 to 17, 71% adults 18 to 64, and then almost 90% 65 and up. With the booster dose, we're really not doing so well with hardly anyone under 18, and then 28% 18 to 64, 58% 65 and up. We also are seeing some great disparities across the US, even more starkly than we see within our area, New York City. So some major gaps in the inland Northwest and in the South in terms of vaccine coverage, in terms of first dose initial series. And then you can see in yellow on the bottom, the booster dose, where you really have very little coverage. But it's concerning, for example, in the initial series, Alabama is at about 50% coverage. So half of people not having completed their initial series yet in our currently most lagging state. So a lot of progress to be made. Next slide. And then I won't go too deeply into this because the next seminar will actually focus exactly on this issue. but the disparities are even more stark globally. So this is the number of doses per 100 people. So some countries you can see are well above 100 because people have had multiple doses per person. But you can see that there are countries that are really lagging in vaccine coverage, and most prominently in sub-Saharan Africa, in the middle of this map, where there's a very small percentage of the population vaccinated. So globally, we're above 60% of people vaccinated, but countries are lagging in access to vaccines. Our next webinar is going to focus on global vaccine equity, and that's March 18th at noon. So look out for that registration info coming soon. But we'll just move on for now to just one final topic for today, which is our prevention measures, our non-pharmaceutical interventions. So everything that's not a vaccine or a test or a quarantine policy. Next slide, please. So our COVID-19 prevention measures, we can talk about, the what, the when, and the how for relaxing these measures. So first, the what. Our prevention measures, I think a good framework for thinking about them is which measures do we always keep in place regardless of the next wave, which measures are only sometimes going to be in place depending on how high transmission is, and which measures are we going to avoid as much as possible, but rarely we may need to put in place if we have a really bad variant. Our always measures are, we always want people to keep their vaccination up to date. That's a great thing to do. You want to do it well ahead of the next wave because it takes some time to build up that immunity. We always want to promote hand hygiene, staying home when sick. These are great things that COVID taught us how to do better and that will keep us healthier in general. We want clean air exchanges indoors. That's not just a great thing to prevent disease, but also chronic illness. And it just, people feel better when they have clean air exchanges. So hopefully we'll continue to make progress on this and keep that in place. And then testing for people who are symptomatic with COVID symptoms and for some priority populations like our long-term care facility staff, hopefully is here to stay, so that even if transmission comes down, we'll still be monitoring in those populations to make sure we're not seeing outbreaks. Then we have our sometimes measures. So these are the things that we want to have in place when there's substantial transmission, but that we can ease up on when transmission is low. And those are our mask requirements, our proof of vaccination, our capacity limits, and avoiding large events and gatherings, and then general population testing for people who are asymptomatic. And then the things we want to avoid, so closing schools, businesses, travel bans, postponing elective and preventative medical care. These are really things we would only think about if there were another surge that was very intense with a severe variant. So where are we right now? The purple arrow shows you that we have the sometimes measures in place in many places. Some jurisdictions are getting ready to remove these sometimes measures. And if the forecasts are correct, we're going to slide over to the left and keep these always measures in place, start to relax some of the sometimes measures as transmission comes down. Next slide, please. So that's what can be relaxed. When can we relax? In my opinion, the answer is not yet. And you can see the reason here. This is the CDC map of US counties. Basically everywhere right now, transmission is still high. New York City and the Northeast in general probably will be the first region to get down into the substantial zone. Our own models are saying we're going to dip down into substantial here in New York City probably within the next week or so. So that will be nice when we get there, but that's still substantial, so still a ways to go until we get to moderate and low transmission. So hopefully that will happen soon if we don't see BA2 driving another uptick or a big shoulder of the current wave. We're thinking by the end of March, most of the country, if there isn't another variant, will be in moderate or low transmission. So just keep in mind, variants introduce uncertainty, but the most likely thing is we'll be able to slide to the left of that graph that you saw on the previous slide and start to peel back some of our sometimes measures. And then just a last slide about the how. This is, I would say, the non-pharmaceutical measures are the trickiest because in many places there are not mandates and it's really up to the individual, and that can put a lot of pressure on people having to make these tough decisions day in and day out. So, just some thoughts. One is set expectations. The relaxation will not be immediate. We're still in high transmission right now, and future waves are likely. So even if we relax, we'll have to put back our sometimes measures probably at some point in the future to get through another wave. So, giving time for the measures to come off, also giving time for ourselves, people who are traumatized, people who are healing from, what people have been through in this pandemic. I think really prioritizing recovery right now with as we start to get a little bit of a breath, be able to catch our breath a little bit from this wave, catching up on missed healthcare, economic and educational losses, restoring social connections and activities that are really key to well-being. These are really the things to focus on. And then also prioritizing the most vulnerable, the hardest hit. So children who have suffered so much in the pandemic, low-income minorities, caregivers, lots of other populations that have been really hit the most. And then people struggling with physical and mental health who have had to put a lot of things on hold for the pandemic. So really, as we start to catch our breath, as we start to get a little bit of space to get our lives back, really prioritizing those things first, I think will be important. So I'll wrap up there and take any questions that you have.
So this is Sheila. Thank you, Doctor, for all of the relative and important information that you've just given to us. I know you are open to taking some questions from our participants here today. So the first question will be, excuse me, do you think we will continue to need to wear masks indoors at schools and work for another year or two, or is there a period of time that you think that we might not have to wear the mask?
Yeah, in my opinion, I think the masks will be able to become optional sometime before the end of March, actually, which is not too far away, maybe sooner here in the Northeast, where we're coming, we went up first, we're going to come down first, and later in other parts of the country. That's not a certainty, right? We could get another variant. BA2 could end up, doing something different than what we expect it to do. So we can't count on it, but that's the most likely thing. So you start looking forward to that. Some people who maybe have really vulnerable family members at home or who themselves are medically vulnerable might choose to keep the mask on. And I think it's also important not to shame or pressure those people. It's great if you want to keep your mask on a little bit longer, but we can take the mandates away. And for people who are not high risk, they can enjoy seeing smiles again in person, which will be nice.
Thank you. Because I actually heard today, listening to the news about, we were talking about socially distancing for 6 feet. And I actually heard today that they said 3. Is that something that is like when you talk about the substantial, when you just showed your previous chart, is that what you mean when you say coming into a substantial rate? I think that's, did you say substantial or sustainable? One of the two, I can't remember. Is that what you mean by that?
Yeah, so we're going to hopefully the whole country is high, and we're going to go to substantial, then we'll go to moderate, and hopefully we'll go to low without another variant kicking in. So looking ahead to that, we'll also be able to reduce the physical distancing, the capacity constraints until the next wave. They're sometimes measures, so they will come back. And the 3 feet is an interesting one because it's really been case by case. So schools, for example, went from the 6 to the 3 feet because that's what they had to do to get all the kids back in the classroom. And they decided it's too damaging to have kids home for half of their school time. And so they were going to relax the distance and put in some additional air purifiers and other measures in the schools and do more testing. So it's really a trade-off, what do you relax first? But if it means doing something that's really important to us as a society, and definitely having kids in school is just super high priority, then that will be one of the earliest measures to relax.
Thank you. Why do you think that there have been so many variants, and why do they seem so different And do you think that this will keep happening?
Why are there so many variants? Because there have been just a mind-blowing number of infections with SARS-CoV-2. Every single person who becomes infected is another opportunity for the virus to mutate. So when this virus just sweeps the globe and goes through all of humanity, it just has so many opportunities to create new variants. And now there are these question marks that, can it also go into animals and get even more mutations and then spill back into people? That's not really understood yet, but that could be another source of variants. So the highest priority in terms of stopping these variants from coming at us is tamping down global transmission with high quality vaccines and access to those vaccines everywhere, no matter what someone's nationality is or what their income is. And then, the other things that I mentioned will be important. We can anticipate that the variants will come, but I think if we really try, we can also stop some variants in their tracks by detecting them early, by having good tracing and containment, which in the US, we still need to learn how to do that well, and also speeding up our vaccine updates so we can get updated vaccines. We don't have to wait 3 months to have a variant-specific vaccine.
Thank you. We know that we just were able to have the vaccine passed to allow children, at a certain age and teenagers. Do you think that there will be authorization for them to take booster shots?
Yeah, I think that's definitely coming. We can look forward to more authorizations. I know the FDA will be reviewing the children under 5 a little bit later than we hoped. That we're gonna have that review in the spring, and then reviewing the safety and efficacy of booster shots in younger populations. So all of that is coming along, and there is a certain sense to really focusing first on the older populations because the risk of COVID is so much higher, but it is the natural next thing to do. So it's something we can all look forward to.
Thank you. Do you think that with this being an ongoing aspect of how we're living today, that this will become a need as taking a flu shot, a yearly flu shot?
Yeah, that's something we don't know the answer to yet. That's a pretty likely scenario, that we have to get a COVID shot every year or every few years, like we do with other vaccines. Tetanus is every 5 years, flu is every year. On the other hand, there are some vaccines where you have a several shot series. Some vaccines you have a 3-dose series and then you're done. And I think we just don't have the data yet to know whether is this a 3 or a 4-dose series and then you can be done, or are you going to need to get the shot regularly? So we just have to be open-minded until we get the data.
Yes. What entity or organization do you recommend that we follow for directives or updates concerning guidelines concerning COVID in our jurisdictions or cities? And do you have sites that you particularly trust?
Yeah, first I just want to acknowledge that it's been a tough time where guidelines have been changing really quickly, and sometimes the government, CDC, federal guidelines get out of sync with the state guidelines, get out of sync with the city guidelines. And it's confusing and hard. So I just want to say, my heart goes out to people who are just struggling to stay on top of everything and stay up to date. And the guidelines are a bit confusing. But it's, that's sort of the hierarchy. So if you have, different guidelines for your local city, those are probably really customized to your population, your situation. Then you can look up to the state health department guidelines, and then you can look up to the CDC for the broadest guidelines that are basically applicable in all populations. Here in New York City, here in New York City, I love the Department of Health and Mental Hygiene website. They have this really great data dashboard that those first few graphs that I showed you come from. And so you can take a look at our cases going up or down. You can look up your own zip code. You can look at vaccine coverage in your area. That can be a really great place to just check in and see how we're doing.
What factors do you think can explain why the vaccine rates in the Asian community are higher than other groups nationally?
I think there are a number of factors related to trust and sort of related to how we think about vaccines. In general, in countries in Asia, we've seen that they take a slightly different approach than we do in the United States, and they tend to see higher compliance with certain guidelines. So I told you before about contact tracing and needing to get better at containing variants.
Yes.
I look at countries like Taiwan and South Korea. They have contained these huge outbreaks. South Korea had an enormous outbreak and was able to avoid a national shutdown by doing really effective contact tracing and getting in touch with every person who was exposed and getting them to quarantine, which we've never been able to do here in the United States. In Japan, in some areas, before COVID, at the height of the flu season, some schools would actually close for a couple of weeks in the peak of flu transmission, and that can really help to bring down transmission. Or culturally wearing masks in the peak of that respiratory season. So maybe those are some habits that the rest of the world will pick up now after this pandemic. And that also extends to vaccination, to really just a lot of awareness. The first SARS outbreak was in Asia as well, so there's just a lot of public understanding and awareness about these viruses. And then, clearly there's so much more that goes into trust, into, populations that have real historical reasons to be thinking about mistrust in medical institutions, and that need to do a lot more talking to really get over those barriers to trust and get that vaccine coverage up.
Yes, thank you. What changes in messaging do you recommend surrounding boosters given the low numbers?
Yeah, so I think a big one is we have this term fully vaccinated, which in most places right now means just completing the primary series. And it turns out Omicron had so many mutations that primary series wasn't enough. And also it turns out after that primary series, the antibody rates that you get start to go down and you need the booster. And so now there's this new term that people are using, which is up to date. So you can be fully vaccinated, but not up to date. And I know it's a lot of different terms that are confusing and to different people might seem to conflict with one another. So I think one way forward is really the CDC and a lot of health agencies are converging on this term up to date. And maybe we can all just really buy into that term. So it's not enough to be fully vaccinated. You need to be up to date on your vaccination, and that includes any recommended boosters.
And that would also include immunocompromised to take the second dose as well as the booster?
Yeah, so people who are immunocompromised are going to be taking up to, a ways out from their vaccination, up to 4 doses of the mRNA, or if they started with J&J, up to 3 doses. So they'll take that first primary series that everyone takes, then they'll get the additional dose that's recommended for people who are immune compromised another 28 days later. And then when the time comes 3 months out, I think they just shortened it from 5 months to 3 months out, then they'll get the booster shot. So it's an additional shot.
Thank you. Why do you think some people are more susceptible to the virus than others? For example, one of my daughters had the virus, but no one else in my household was infected. We took no extreme measures to keep her separated or isolated from the rest of us.
Yeah, this is a really tricky thing with this virus. It does something that you might have heard the term super spreading, where some people who are infectious, they will infect, an entire auditorium full of people. Someone who's all the way across the auditorium could still inhale one of their particles. And that really has to do with how much virus they're expelling and how much of a fine mist of particles they make. So usually, adults who have big lungs as opposed to kids who have little lungs, they can make more of these particles and they're more likely to be super spreaders. And then on the other side of the spectrum, you have people who, don't infect their spouse sleeping in bed with them all night, even though they're infectious. So, we think about when you say the reproductive number is 1, each person infects one other person, but really it's 9 out of 10 people don't infect anyone, and then 1 person infects 10. It's really very different, and we don't have a great way right now to know who will be a super spreader and who won't. The general trend is that people who are bigger, so adults, are more likely to be a super spreader, and that there are certain environments, so stuffy air, low humidity, close contact with others, singing, coughing, shouting, those are all kind of circumstances where super spreading is likely to happen. But within your home, it's so hard to know, right, who will be someone who infects others and who won't.
Interesting. Can we reduce our exposure to COVID? Excuse me, I said that wrong. How can we reduce our exposure to COVID, and how has this new variant affected minority communities?
Yeah, so we can reduce our exposure sort of through those layers that we talk through. So starting with making sure people in our community who are symptomatic can get tested, people who are exposed get tested and quarantine, and people who test positive are able to self-isolate. And that includes a lot of wraparound things, right? Self-isolating is hard, making sure people can get their groceries, their medicine. In New York City, the health department has a number of services like that. So if Test and Trace reaches out to you because you're positive, you can get access to some of these services to help with self-isolation and quarantine. And then, the next layer is vaccination, of course. Great, no matter what, get up to date on vaccination. And then that final layer is those precautionary measures. So, and those ones, there are some we'll always have in place, I hope, like lots of fresh, clean air, any place we're indoors. And there are some that we will probably only have in place when transmission is high, like wearing masks and staying away from crowds.
Thank you. As COVID-19 moves from pandemic status to endemic status, what future roles do you foresee for community healthcare workers working directly in COVID emergency response programs?
Yeah, so when people say endemic, it has the word end in it, but it doesn't mean that we're going to be at the end, right? The endemic just means it's kind of predictable. It's, we know it's here, and it's neither new nor is it going away. But very bad things can be endemic, right? Malaria kills something like 600,000 children every year in sub-Saharan Africa, and it's considered endemic. Right? Very bad diseases can be endemic. So, it's unfortunate if COVID becomes endemic, and we don't know if it will become milder. And that means that we're going to keep on relying on our health workers and our community health workers to deal with these waves that will be coming again and again. And even if it gets somewhat milder, right? Think about flu is much milder than COVID-19, but it's a leading cause of hospitalization during flu waves. So it's still a pretty serious issue. So I think endemic means really investing in our community health workforce. It means fine-tuning the things that we had to make up on the fly the first time around. Can we do them more equitably? Can we do them better and more efficiently now that this is a regular thing? And really just doing the best that we can.
Thank you. So I have this kind of issue. I'm not asthmatic. So this attendee here says, I'm asthmatic due to the weather changing. I sometimes sound like I'm congested, but people look at you like you have COVID. How can you let them know you're not sick? So I always find myself suppressing coughs or trying to suppress a sneeze, because of that. Because again, like she said, people look at you. Is there a way or any messaging?
Yeah, it's tough. And, we did a study early on in the COVID pandemic here in New York City. And we looked at people who had been exposed, and they did a symptom diary every day for 2 weeks. And a huge fraction of people, we also tested them every day for 2 weeks. A huge fraction of people who never had COVID reported all the COVID symptoms, right? Because it's COVID time, you're paying attention to how you're feeling, right? And seasonal allergies and all these things, or asthma. So, you know, I don't know that there's a lot we can do about just being hyper aware. I do the same thing. I am very aware that when I sneeze or cough, it really upsets people. So, you know, just practicing the standard, if you sneeze or cough, use your elbow or a tissue and sanitize your hands afterward. You know, I think that's really the best that we can do when we're also on our toes.
Yeah, yes. Maybe I will take one more question because we're coming to our time. Is there any indication that immunity increases in the infected? I'm not sure if that's clear.
Yeah, absolutely. So if you're fully vaccinated, so I know this is a lot of people, if you've been fully vaccinated, then you got Omicron on top of it. You have a lot of antibodies right now. Actually, you have pretty good immunity against COVID-19 for at least a while. It is much better to get your immunity from vaccination than infection. So do not go out and get infected. I would never recommend someone to go and try to get COVID to get immunity when you can get it so much more safely from a vaccine. But it is true that getting the infection, and especially if you've gotten the infection on top of the vaccine, it does build up our immunity to the virus.
Yes, thank you. Thank you so much, Doctor, for answering as many questions as we could get into during this time. It's been a very informative town hall. We look forward to the next installment. So I will send it back to you, Dina.
Thank you, Sheila. I think Amy is.
Sure. Thanks so much, Sheila, and Dr. Bershteyn. Really amazing presentation. I don't know if you were able to follow in the chat at all, but I can tell people are super appreciative of all this information. And I did want to remind folks to please complete the poll that just popped up on your screen. I wanted to thank my colleagues at the Community Health Worker Research and Resource Center, along with Dean and myself. That's Nadia Islam, Sue Kaplan, and Sana Lim. And then also our colleagues who are part of NYU-CUNY and the CUNY Prevention Center, Nadia Islam and Sarah Hussein. Please stay tuned for some information on our upcoming webinar in March on global vaccine equity. That'll be with Dr. Boguma Tatanji. She's at Emory University. That'll be Friday, March 18th at 12 p.m. We'll send information out about that as soon as we have it. But yeah, just thank you so much, Sheila and Dr. Bershteyn. That was really just a great overview, really helpful, and just really appreciate you taking the time to speak with us today.
Thank you.
Thank you. Thank you, Sheila, for great moderation. It was wonderful.
That was fantastic. Yeah.
Thank you so much.